Good morning, everyone. I'm so pleased to see so many people here. Thank you very much for coming. You're in for a real treat. My name is Jana Martin, and I have the distinct privilege to welcome you to the 30th annual Katherine White Lectureship Series. We want to thank you for being with us today, and we're honored to have several special guests who will be addressing you throughout the morning. I'll introduce them separately later in the program, but I do want to recognize their being here. We have Dr. Aaron Simon from the Long Beach Unified School District. We have Dr. Andrew Abayan from the Health Department. We also have our keynote speaker, Dr. Scott Hadland. And we also are expecting Dr. Anissa Davis from the Health Department. We're pleased to have her. We were also pleased to be joined last night at an event that we had by Ms. Pineda, who is from the mayor's office. The mayor, unfortunately, was not able to be here today, but sends his regards and support of this wonderful lectureship in the community and what it does in the community. I'd also like to recognize Dr. Katherine White's family, who helped not only make today happen, but also who are making our community better. That's kind of the theme today, is making our community better. So we certainly want to recognize them. We have Dr. White's granddaughters, Becky Qualls, Susan Vaughn, and we want to thank them for keeping Granny's, we call her Granny sometimes, so my apologies if I slip and call her that instead of Dr. White, her legacy. But we also want to introduce and recognize Madison Vaughn, who is Dr. White's great-granddaughter. Very pleased to have everyone here. This family is a very tight-knit family. They do wonderful things, all of them, in their community. You know, it's kind of rare to be in a room with so many people who are different in so many ways. We all come from various places. We've had different life journeys and different life paths. But what is so fascinating and wonderful is that everyone in here has special things in common. For example, a similar passion, mission, and set of accomplishments. You value learning, you work hard, and you love and invest in children and their families with your heart, with your skills, with your humanity, with your patience, with your kindness, with your smiles. And it's that component that is very important for us to recognize. Medical, educational, and social training is very important. It's the person that you are. It's the belief and the passion that you have to make other people's lives better that really, really counts. Sometimes you do that one encounter at a time, maybe one question at a time, one answer at a time, and sometimes one tear at a time. But you're there, and you provide, and you make things better, even in the worst of situations. You have created a legacy of learning and caring, and I want to thank you for all that you do. You're simply amazing. You're also a part of the legacy of Dr. Katherine White, who died in 2005, but whose legacy continues on a number of levels. You reflect the spirit, the brilliance, the spark, and the caring of Dr. Katherine White. She was a pioneer in her time in the field of pediatrics and was a leader without any doubt. She always knew that what was important was the community, the quest for knowledge, compassion, being genuine, and seeing patients as human beings who had special importance in their families' lives and in the community. She knew that community was important to helping patients get better and to heal along with their families. She also knew of the importance of accessibility to quality health care and the importance of sustained financial giving to support efforts for those who cannot financially afford great service. So we know that she made sure that there was enough money to train educators, physicians, nurses, medical staff. Her legacy is why we are here today and why the field of medicine and the lives of so many are better because of her and her efforts. Dr. White's generosity to this medical center was significant. She gave over $2 million to the hospital in endowments and in donations, especially to the Children's Clinic and this lectureship series. Dr. White's legacy also includes supporting her community in other ways that are too numerous to mention today. We'd be here all day, and I know you want to hear from Dr. Hadland, because I know I do. But she was a passionate member of Seroptimist International of Long Beach, a women's service organization here in this community, which focuses on what's best for women and children nationally, locally, and internationally. She was a great contributor to that group, and we are so delighted to have several Seroptimist International of Long Beach members. Dr. White knew the importance of community, and she invested in Long Beach in so many ways. Her legacy lives on. Today's presentation, entitled A Classroom of Teens Every Week, How Pediatricians Can Address the Worsening Overdose Crisis, would have been of very special interest to Dr. White because, one, it features a speaker who's brilliant in the field and a great contributor, a cutting-edge topic with tools for change in our community, and an opportunity for people who love children to gather, learn, figure out how to improve lives even better, and many messages for inspiration and chances for partnership building. Our keynote speaker, Dr. Scott Hadland, is the Chief of Adolescent and Young Adult Medicine at Massachusetts General Hospital and an Associate Professor at Harvard Medical School. He's a bit of an overachiever, which is a good thing. He holds triple board certification in general pediatrics, adolescent medicine, and addiction medicine. There's only a brief profile in your brochure about him, and I'm certainly not doing you justice, Dr. Hadland. I invite you to learn more about him. Some of you may have seen him on national news stations. He does a lot of interviews, a lot of presentations, and a lot of research, and is a gifted writer. He's a pediatrician and an expert on teen health. His research is funded by NIH, and he is working to improve access to mental health and addiction care. He's an educator of healthcare providers who want to enhance their care of children and families. He's a husband and father of two, and of great importance, a caring person who is a community builder and a legacy builder. Dr. Hadland, Dr. Katherine White would have loved you. She would have picked you herself from what I've learned about you and what I know about her. And so we are so pleased to have you here. Thank you, and please educate us.
Thank you so much, Dr. Martin. Can everybody hear me okay? And I'm going to come out and talk out here. Just let me know if the microphone cuts out or if I don't notice anything that's going on. But thank you so much for that really wonderful introduction. From everything that I've learned about Dr. White, I mean, first of all, she is an absolute legend. That much is clear. And I'm so thankful to her family for being here and welcoming me and showing me just such a wonderful time last night and today. So thank you so much. I really think that she would be quite passionate about this topic as well. I'm going to talk about the overdose crisis and how it's worsening among teenagers in the US to the extent that now overdoses have become the third leading cause of death in teenagers in the US after firearms and after motor vehicle crashes. So this is of critical importance to pediatrics, and yet our field has a little bit of catch-up to do. And so my goal today is to help us as a group do that catch-up. And I think the reason that Dr. White would have been just so excited about this field is that I think pediatricians, more than any other specialty, are the best poised to take on this crisis because we're used to thinking about the biopsychosocial model used to thinking about not just medicine, but everything that happens around medicine. We're used to thinking about our communities and prevention. And there really is no better public health topic that we are poised to take on than something like this. And I really think that this sort of way of thinking about the field is just so in line with the person and physician that she was. As we heard, my practice is as an adolescent medicine clinician, and I work in a primary care practice where we're providing addiction treatment to young people. And so we care for young people between the ages of about 13, actually right up to age 30. We'll hang on to some of our patients because we know that transition from adolescence into internal medicine or to family medicine that's more adult focused is really tricky for young people. And so we really kind of hang on to our patients to help ease that transition. And in so doing, we care for young people who might struggle with nicotine use disorder, alcohol use disorder, cannabis use disorder, right out to young people who might be using heroin or fentanyl, injecting drugs, using cocaine or methamphetamine. And so we see a lot of different things. Today, I'm really going to be focusing on opioids because opioids and fentanyl are the key driver of overdose deaths here in the US among teenagers, including here in California where there is a rising problem. And so I'm looking forward to talking to you today, and I've really tried to make this talk action-oriented so that we can talk about specific and often easy things that we can do to incorporate right into our own pediatric practices so that we can make a difference starting today. And I have no conflicts of interest to disclose. And I want to start just by grounding this in a story. Zach's story I share with you today with the permission of his mother, Laura, who's become a good friend of mine as I've done advocacy in this area. Zach grew up in Sacramento and, like many teens, was thriving and doing really well. He was really involved in his school theater. He had a lead in the high school musical. He had a lot of friends. He was really active. He had actually been accepted early to UCLA to study psychology and was really excited for this. And in his senior year, in around the Christmas holiday, which was his favorite time of year, he tried a pill that he and a friend had purchased off of social media. And he wasn't somebody who had really done a lot of experimentation to his family's knowledge, but he tried it. And as we'll learn, sometimes a single time that you try something can be deadly in an era in which the drug supply is so dangerous, and that's what's affecting teenagers. Zach died the day after Christmas of 2020 during COVID when so many teens had experienced some isolation, and I don't know if that's what drove him to experiment, but his story is tragic and one of more than 5,000 teenagers that have died in the last 3 years. And again, largely driven by fentanyl, largely driven by an extremely dangerous drug supply that's really unlike anything that we've seen before. And so my goals for today's talk are really to highlight, first of all, the ways in which children and adolescents haven't been spared from this overdose crisis that we hear so much about on the news. And so we'll spend time during today's talk, first of all, describing the epidemiology of substance use, opioid use, and substance-related harm as it pertains to adolescents and young adults. We'll talk about how to prescribe opioids in a manner that helps reduce the downstream consequences that we worry about, like addiction and overdose, because I think that this is part of our pediatric practice, and I know that there are some practitioners who have already approached me today telling me that they prescribe opioids as part of their practice because they need to, and so we should talk about how to do that safely. And then last of all, we want to make sure that we ensure evidence-based screening so we can identify young people who might be using opioids, and then make sure that they get connected to evidence-based treatment. So with those goals, we'll start off by talking about the epidemiology of this problem. So this is what drug overdose deaths looked like across the United States in the year 2021, the most recent year for which we have sort of very clear, full, granular data across all age groups. This is everybody. This is adolescents and adults. And you can see that there are numerous hot spots across the country. There are some places where the shading gets really dark. And one thing I will say about this crisis is traditionally we've thought about it as one that has largely affected parts of the Midwest and parts of New England in particular. But more recently has spread kind of everywhere. And in fact, if we look at the most recent data, some of the nation's biggest hotspots, meaning the places where the most teens are overdosing, are actually right here in Southern California and in neighboring Arizona. And so even though you might look at this map and see that California is actually lightly shaded, if you were to zoom in and look at LA and greater areas and Southern California, you would see actually that these are some of the highest overdose counties across the US for teenagers. And we're at a point where across all age groups, there's a death every 5 minutes in this country caused by overdose. So I think key questions that we need to think about as pediatricians aware of this crisis is, first of all, what's happening with youth overdose rates and which opioids are involved? What percentage of youth actually use opioids non-medically? How much do we need to worry about this? When does opioid use rise to the level of a formal diagnosis of addiction? And then what are some of the neurobiological underpinnings of addiction? And I'll talk a little bit about this because I know that when I was going through medical school in the early 2000s, I didn't get a lot of education on this. And so I want to spend a little bit of time doing some catch-up on the biology. So this is what's happening with youth overdose rates across the United States. This is from a paper that we published in January of this year using the most up-to-date data that were available on teenagers aged 14 to 18. And what you can see is that this figure goes from, on the left here, 2018, right out to December of 2022. And you can see that we had some overdose deaths that were occurring, but they were actually relatively flat or level in 2018 into 2019. Note that even before COVID hits, in sort of late 2019 and early 2020, you start to see this rise. But then COVID hits, and all of a sudden there's a big jump up. And we now are at a point where two things have happened. One, we've reached a new sustained high in overdose deaths among teenagers. And second of all, if you look at the slope of this line, that slope continues ever so gradually to go upwards. And so this crisis is actually going in the wrong direction. If you look at what drugs are underlying these overdoses, well, the answer is fentanyl. And we've heard a lot about this, I'm sure, in the news. This is a figure that goes from 2010 on the left to 2021 on the right. And each of these different lines represents, among teenagers aged 14 to 18, what are the drugs that are causing them to overdose and experience a fatality? And across all the substances, you can see that these lines all stay sort of relatively close to the bottom here, except for this gray line that really starts to pick up in 2016, 2017, 2018, 2019, and then boom, 2020 and 21 just absolutely skyrockets. Well, that line again represents fentanyl. And so we're going to talk a lot about fentanyl today. But it's worth noting that yes, fentanyl is involved in at least probably, I put up here 9 out of 10 of all overdose deaths in teenagers. You get different numbers in different places. It's at least 3/4 of all overdose deaths. But actually, a lot of these deaths aren't just fentanyl, but they often in young people will include other substances like cocaine, benzodiazepines, or methamphetamine are the 3 most common other substances. So I just say this because we're going to talk a lot today about opioids, and we, in the news and in the national conversation, talk a lot about opioids and fentanyl, but there are other drugs at play here that sometimes we look past. And what's really curious about this crisis, and particularly tragic, is that if you look at this figure here, this is the percentage of teenagers who, at the time of high school graduation, across the country, at the time of high school graduation, what percentage have ever used an opioid for non-medical purposes, meaning that they've used an opioid in a way that wasn't prescribed to them, or maybe they were prescribed the opioid, but they used it in a way that was sort of misused. They used it in a way that was not the way it was intended, potentially for recreational purposes. Well, if you look at this line, we were actually at a point in the sort of 2000s and early 2000 teens where this percentage was really quite high, that it was about 1 in 8 high school seniors had misused a prescription opioid by the time they graduated. And yet we have this enormous public health success where in recent years, we've actually gone down to kind of historic lows here. That actually, if you look across all substances, with the exception of cannabis, across all substances, including alcohol, cigarettes, any other substance that you can think of, we actually have this enormous public health success where fewer teenagers than ever are using substances. These lines are all going down. So we actually have a really strong, healthy group of adolescents who are using fewer drugs than ever before. And yet the drug supply has become more dangerous than ever before. So even as these lines all go down, the rates of overdose are going up. And that's part of the tragedy here, is that we have this public health success that we don't talk nearly enough about. And even though I say we've gotten to this point where, like, good, we've gotten the rates of substance use down, if you do the math, in 2022, we still have about 1 in 31 high school students who have used an opioid for non-medical reasons at the time that they graduate from high school, which is about a student per classroom. And we should be concerned about that because if you think about all the classrooms across the United States, this is a public health issue that mounts, and that's relatively common, and reaches the prevalence of common conditions that we think about all the time, like diabetes and hypertension, for example. The other thing that I think is important to note about why youth matter so much in this crisis is that opioid use and opioid use disorder are actually pediatric onset conditions. If you ask all adults who are in treatment for addiction across the United States, when did you first start using opioids? They'll tell you that the first time they ever misused an opioid, 2 out of 3 of them will tell you that the first time they misused was before age 25, and 1 out of every 3 will tell you that it was before the age of 18. So this is a pediatric onset condition that we need to be thinking about. And of course, these data that I presented about prescription opioid pills and misuse of prescription opioids are really critical because, as I said, we are in an extremely dangerous drug supply market right now, where actually what's on the market right now, if you go onto Snapchat or if you go onto Instagram or TikTok and you buy a pill off of somebody who wants to sell it to you, or if you use a pill that somebody gives you in a social setting, it's actually more likely than not that's not a real prescription pill. We've all cut back as doctors on our prescription opioid prescribing. So what's actually out there are counterfeit pills, most commonly in the year 2024, illicitly manufactured in Mexico, incorporated into our drug supply. And these pills are made to look like real pills, but actually contain fentanyl in them. They don't contain the real thing in them that you think is in there. And so these are real images from the US Drug Enforcement Agency of real pills alongside counterfeit pills. So on the left here, this is a real oxycodone tablet, and beneath it is fake oxycodone that contains fentanyl in it. Fentanyl is cheap, inexpensive, easy to incorporate into the drug supply, highly potent, and so you can make something that has the same sedating properties as oxycodone, feels like oxycodone, has the pain-killing properties of oxycodone, but in an illicit drug supply where it actually contains fentanyl and with very poor quality control, such that some pills have a lot of fentanyl in them and some pills don't have a lot of fentanyl in them. It becomes really confusing and difficult for people to know what it is that they're actually taking. And many teens may not realize that what they're taking is actually a fake that could have really high levels of fentanyl in it. In fact, the DEA tells us that about 6 or 7 out of every 10 pills that are out there have enough fentanyl in them to potentially be lethal for a teen who has no prior exposure to opioids, doesn't have any tolerance to opioids. This middle panel here, this is real Adderall on top. This is counterfeit Adderall underneath that contains methamphetamine in it. And on the right here, this is real Xanax on the left, alongside counterfeit Xanax on the right that contains fentanyl in it. So again, you might think that you're taking one thing, but ultimately what you get is something very different. And so it's no surprise then, and this is why I named the talk One Classroom a Week, that we're now at a point where 22 high school students die every week across the country from fentanyl overdose, and it's really driven by these pills. It truly is the equivalent to a high school classroom of teenagers dying every week across this country, and those numbers are getting worse. So if you look at 2021 data on teenagers between the ages of 10 and 19, we have some new data that I put up here that talk a little bit about the context in which teenagers are overdosing. These data showed us that at least 1 out of every 4 overdose deaths in teenagers involved counterfeit pills in 2021. I think this is an enormous underestimate because often teens will just buy one pill, take one pill, and then you have nothing to test. And so you know that the teen died of fentanyl, but you don't know what the source of that fentanyl was. Also, a lot of jurisdictions don't actually do routine drug testing if they do come across pills at a scene of death. And so I think this is a vast underestimate. This is just the percentage that we know about. But what's fascinating and really tragic is that most overdose deaths in teenagers, about 60% of them, are happening in their homes. So they're not happening in schools or at parties or in streets. They're actually happening in adolescents' homes. And 2/3 of the time, there's actually somebody else at home when this happened. And that was the case with Zach. His dad was in the house when he overdosed. The but 60% of the time, the teen is pulseless by the time emergency medical services arrived, and naloxone, which is the overdose reversal agent that we'll talk about today, is given in fewer than 1 in 3 overdose deaths. So there's a real opportunity here for us as pediatricians to talk to families, to make sure families are prepared to recognize the signs of overdose and then act if something happens. I want to take a quick moment and just talk about addiction, because we're actually going to spend a little bit of time talking about addiction today and how to treat it. There's a few different things going on right now in the crisis, right? So you have some teens who might be like Zach, who have no history of addiction, aren't really using substances, but experiment, and that can be tragic. You have other teens that might be similar to that, but have a mental health problem, like untreated anxiety or depression, and they might try one of those pills thinking that that's going to bring them sort of a sense of relief from their symptoms, and then they experience an overdose because it's not a real pill. But there are a subset of teens that have genuine, bona fide addiction to opioids. And in fact, the prevalence of true opioid addiction among teenagers in the US is about 1 in 100, about 1%. So this is actually something that's going on everywhere, and again, has a prevalence that approaches many of the conditions that we see in pediatric practice. So I want to take just a moment and talk about addiction and talk about some of the neurobiological underpinnings so that we know what we're dealing with here. When we talk about addiction, we're talking about what the DSM-5, or the Diagnostic and Statistical Manual 5, calls opioid use disorder. And opioid use disorder is opioid use occurring over 12 months with at least 2 of the following 11 criteria. Now, first of all, this is a kind of adult-oriented definition. I would not wait 12 months to make this diagnosis, right? Like, we know that teens can escalate really quickly in their substance use. So I look past that 12 months and I intervene and call it opioid use disorder before 12 months. Most pediatricians do too. The other thing I will say is that lists of criteria like this, when you've got 11 criteria, can be very overwhelming. I'm an addiction doctor. I couldn't name all of these for you. But what I can do is that I can clump them into 3 buckets that I think are very important for us to know. The first bucket worth knowing about when it comes to a substance use disorder, and this definition applies whether you're talking about opioids or cannabis or alcohol or nicotine, whatever it is, the DSM-5 has the same set of criteria for all substances. But the first bucket of 3 that I think of are these final 2, which are tolerance and withdrawal. Tolerance is the idea that when you use opioids over and over again, you start to get to a place where you have to use more and more to get the same effect that you used to. Or worded differently, if you take the same amount that you used to, you won't get the same effect that you used to. You won't get that same euphoria. And then withdrawal is the idea that if you're using opioids over and over and then you stop, you'll get that characteristic set of symptoms that are really uncomfortable, right? You'll get large pupils, you'll get goosebumps, you'll sweat, you'll feel irritable and agitated, you'll feel diffuse pain, you'll get diarrhea, your blood pressure goes up, your heart rate goes up. That's opioid withdrawal. So that's the first set of criteria, physiologic dependence on opioids. Now, for those of you who treat patients who are on long-term opioids, say, patients with sickle cell disease, a patient having just these 2 final criteria alone, just the physiologic dependence alone, does not meet criteria for addiction. In order for it to meet criteria for addiction, you have to have some of the features that I'm going to talk about in a second. So the second bucket of things that I think about are items 1 through 4, and all of these represent loss of control over your opioid use. So you're spending more and more time or money on opioid use. You're using them more and more than you meant to. That's different from, say, again, a patient who might have sickle cell disease who's taking opioids on a long-term basis. If their opioid use isn't getting out of control and isn't escalating, that's not addiction. And then the third bucket that I think about are items 5 through 9, and these are all negative consequences resulting from your opioid use. And so you're using them in hazardous situations. Maybe your relationships with your family and friends are breaking down. Maybe your education or employment is starting to be in jeopardy because of your opioid use. So 3 components to addiction. 1 is physiologic dependence. 2 is loss of control over your opioid use. And then 3 is negative consequences resulting from your opioid use. And so again, I just want to differentiate being on chronic opioids for pain treatment. You might have tolerance and withdrawal, but those 2 things alone are not enough to call it addiction. You really need to have loss of control over your use and negative consequences resulting from your use. And if you want a simple litmus test, let's say you're caring for a patient, again, I'll give the example of sickle cell disease because many of our patients with sickle cell disease are on long-term opioids. Ask yourself the simple question, does this patient's functionality get better or worse when they take their opioid. If the opioid is treating pain and making them more functional, making them able to go to school, go to work, have relationships that are fruitful, then that's not addiction because the opioid is making them more functional. It's addiction when an opioid makes somebody more dysfunctional. And then the last thing I'll say is that the more of these criteria you have, we'll call you mild, moderate, or severe. Most of the patients that I see, by the time they get into my clinical practice, they're at least moderate and very often severe because it takes a while often before these problems start to bubble up. And then I just want to take a second to talk through this somewhat overwhelming neuroanatomical figure. And I only do this not because I think you need to memorize this, but actually because I think that this actually can give us a humanizing view of people who struggle with addiction, right? So we all know and probably have seen that when people with addiction come into the hospital, maybe they're admitted, maybe they're in the emergency department, that we and our colleagues will see them behave in ways that sometimes don't make sense to us, right? We'll know that they stole money from a loved one in order to use drugs. They might be angry or lash out at us as a healthcare provider and seem really fearful and irritable in our presence. And this all has a brain basis. Addiction is a brain disease, and there is a basis for all of this behavior. And I think that's important because this can help to humanize people because we can understand that their behavior is actually part and parcel with the disease. So when we think about what goes on in the brain with regard to addiction, there's kind of three things that are worth knowing about. The first thing worth knowing about is when somebody uses opioids, or any substance really, they go into this blue part of the figure, which is binge and intoxication. So no matter what substance you're using, when you use it, you get psychoactive properties, you have some degree of intoxication. With opioids, you might feel some euphoria, at least initially when you're first using them. And parts of the brain that act up are parts of the reward center, and you have that release of dopamine that many of us learned about in medical school, and that release of dopamine kind of feels good. That's the euphoria. And then the second part is when you're not using opioids, when you come down from opioids, especially if you've been using over and over again, you'll start to experience withdrawal, right? And sort of negative affect. This is driven by parts of the brain that are responsible, like the locus coeruleus, again, not a name you need to know, but responsible for causing a flood of norepinephrine. So you get this adrenaline drive when you're going into withdrawal. And that's what causes somebody to have goosebumps and sweating and high blood pressure and sort of feel irritable. Other parts of the brain that light up include the amygdala, which we know is part of the brain that's responsible for sort of fear and emotion. And that's why when somebody's in withdrawal, they seem really fearful, they can seem angry, they can seem irritable. And then this last part is sort of a newer conceptualization that we've come to understand about people who have addiction, and that is that when somebody is not sort of experiencing binge and intoxication and has maybe finished withdrawing from opioids, their behavior might seem different to us. And that's because parts of the brain that are responsible for preoccupation and anticipation start to light up. And so as a learning disorder, as a learning condition of the brain, when somebody repeatedly exposes their brain to opioids, parts of the brain that are responsible for planning and behavior, like the frontal cortex, start to become really geared around the next time that somebody is going to use, so that somebody starts to experience really strong cravings to use opioids when they're not using. Somebody will, if they go to a place that they used to, a place on the street that they used to use opioids, they'll be triggered to want to use. If they're spending time with somebody that they used to use drugs with, they'll feel triggered to want to use. If they feel emotional, anxious, upset, and that used to drive them to want to use opioids, they'll still feel that. And it's because the brain is plastic and starts to build itself and its neuronal networks around a set of behaviors and responses and cues that all sort of drive addiction. And this is why people's behavior can sometimes change and seem irrational to us when they have addiction, because parts of their brain have literally become rewired around repeated use. And I think that's important for us to understand because it provides a biological basis for a behavior that sometimes can seem confusing to us. Okay. I'm going to talk now a slight shift to just dive a little bit deeper into prescribing opioids appropriately. And I think this is really important because one thing we do in pediatric medicine is we treat pain, especially we treat severe acute pain. And I want to talk a little bit about how we can do that safely and effectively. I'm actually chairing an AAP subcommittee that's developing a new clinical practice guideline on how to do this. And we hope to be publishing it a little bit later on this year and presenting it in October at the National Conference and Exhibition. So soon we hope to have some pediatric-specific guidelines that we can all turn to. And I'm going to share some of the sorts of themes that are coming out of that evidence review so that you can start to incorporate some of these practices into your clinical care. And I just want to editorialize and say that, again, when I was in medical school, I started medical school in 2004, and I remember so distinctly hearing pain is the fifth vital sign. We should always treat pain. It's cruel and unusual not to. Somebody who has pain who's treated with opioids can't experience addiction, so you should just prescribe. And then about 5 to 10 years later, we realized there was an opioid overdose crisis that was starting to fuel or starting to rev up, and a lot of this was driven by overprescribing of opioids by doctors, and so you started to see this huge ratcheting back on prescribing, and we had actually a lot of emergency departments and clinics that said, hey, we don't even prescribe opioids anymore. We're getting out of that business. It's just too difficult for us, and we don't want to take that risk. Well, that also doesn't make a lot of sense, right? Opioids are a mainstay of medical practice. They're very effective at treating pain, and sometimes we need to, right? So what I want us to walk out of here with is hopefully a recognition that there are some instances in which we still want to prescribe opioids, but we just want to do so in a way that's thoughtful when we do it. And so with that as the backdrop, some key questions I think we can all ask ourselves as pediatricians are, first of all, what do recent trends in opioid prescribing in pediatrics look like? Next, what's the risk that somebody who you prescribe an opioid to is going to go on to have a problem with either addiction or overdose? Which youth are at risk of developing those problems? And then last of all, if you are going to prescribe an opioid, what are some things that you should do? So here's what's happening with opioid dispensing rates across the country. They have plummeted. They've gone way, way down. And they've especially gone down in the group of young adults that had quite high rates of opioid dispensing and have come down in more recent years. And I think some of this is, for example, third molar extractions are very common in this age group. And for a long time, the practice was to prescribe opioids for those, and we've moved away from that. But then there's also other painful things that happen to young adults, who might have injuries or whatever. And I do just want to add one sort of editorializing comment here, is that we might look at this and say, oh, this is good, right? Opioid prescribing has gone down. That's a good thing. This probably also represents a decline in people who might have needed an opioid for pain but didn't get it because we withheld it from them. So in the aggregate, this might be good, but I bet there were some patients, including pediatric patients, who had undertreated pain as a result of these declining prescribing practices. And very fortunately, we have some good data that show us who's at risk of developing a problem with opioids when we prescribe them. And so our group and a few other research groups have done some analyses that all converge on the same idea, the same set of risk factors that tell us who is at risk in the pediatric population for going on to overdose or have an addiction if we give them an opioid. And actually, the data are relatively reassuring. There are different numbers out there, but our group found that in the year after we prescribe an adolescent or a young adult an opioid, actually only about 1 in 300 to go on to have a problem. So if you as an individual clinician prescribe opioids to 300 adolescents and young adults, only one of them is going to go on to have a problem with overdose or addiction. That's actually a pretty favorable percentage. So 299 times out of 300, you can feel okay about the opioid you're prescribing. Unfortunately, again, if you multiply this out across the entire country, this is where you start to have a potential problem. But fortunately, studies have shown what are the risk factors. And there's some prescription-related risk factors and then some patient-level risk factors. So prescription-related risks include the 3 that I've listed here. And that is that, in general, when we're treating severe acute pain, we should not prescribe long-acting opioid formulations like MS-Contin or OxyContin. Again, different, for example, in patients with sickle cell disease who may need that coverage. But for severe acute pain, like a child has broken their arm or whatever it may be, we should not use long-acting opioid formulations. High daily doses of opioids are associated with greater risk for addiction or overdose. That's probably not a surprise. And then durations of prescriptions that are 7 days or more are associated with addiction or overdose. And that's probably just because there are lots of leftover pills that can cause a problem. There's a few different patient-level risk factors, and interestingly, across studies, these have the bigger odds ratios and relative risks, meaning that it's actually the patient more so than the medication that sets up the risk environment. I've listed a few different things here: male sex, older age, family history of any addiction, chronic pain. Those are sort of marginal risk factors that are, odds ratios a little bit greater than 1. The real concerning ones, though, are mental health disorders that go untreated. So youth who have untreated mood or anxiety disorders have a 4 times greater risk of developing a problem with addiction. And I put 3 asterisks next to this last one, other substance use, because here the odds ratio, and I'm not joking, is like 20, meaning that who's at risk of having a problem with addiction when you prescribe an opioid? It's teens and young adults who are already using other substances. And those other substances, by the way, are most commonly nicotine, alcohol, and cannabis, the common things. So those are the teens that are at risk of having a problem. Now, as we'll talk about in a second, that doesn't mean you don't treat pain in those patients, because everybody who has severe acute pain and might need an opioid should get the opioid if it's clinically indicated. But it means you follow them more closely. Again, something that we as pediatricians do really well, which is why I think we're well poised to do this work. So what are some best practices? Again, a lot of this is going to come out in this clinical practice guideline that we hope to release in upcoming months. But before we even prescribe an opioid, there are things that we can do to kind of stave off the need to prescribe an opioid. The first thing we can do is we can maximize our non-pharmacologic options, right? So some patients benefit from physical therapy to mobilize a joint that's sore. Relaxation techniques to help with the anxiety of experiencing pain can be very helpful. And then, of course, we have non-opioid options such as NSAIDs and acetaminophen. So we should maximize those as we move towards an opioid, if we even need one at all. Then, if we think we're headed towards prescribing an opioid, you want to conduct an assessment of risk factors. And as I showed on the last slide, probably the single greatest risk factor is, are they using other substances? So you want to try to understand, are they using cannabis, alcohol, nicotine, or other things? And again, I'll talk about how to do that in a few slides from now. Do they have untreated mental health problems like a mood disorder or anxiety that's going untreated? And do they have a family history of addiction? And by the way, family histories of addiction aren't substance dependent. In fact, if you look at teens who have opioid addiction, and you look one generation up at their parents and you ask yourself, what's the most likely substance that a parent struggles with when a teen has opioid addiction? It's actually alcohol. And it's because alcohol use disorder is the most common type of addiction in the country. And so you have to kind of look across substances as you do that risk assessment. And again, even if a young person has these risk factors, you still treat them with an opioid if they need it. You just do so very carefully with good monitoring and very close follow-up. And then the last thing you want to do is check your state's prescription drug monitoring program. And here in California, as many of you will know, there is one, and they typically are present across every state in the US. When you do prescribe an opioid, best practices are to, based on those risk factors that we just talked about, use the lowest effective dose of a short-acting formulation, and don't use long-acting opioids for acute pain. So what do? I'll give you an example. I have patients who have opioid addiction and see me for treatment of their opioid addiction, but undergo painful surgeries or painful dental procedures and need an opioid. I still prescribe to them. Even though they have an opioid addiction, we can safely use an opioid for treating their pain in that setting after a careful conversation and with good monitoring. And what I'll do is either hydrocodone or oxycodone, typically 5 milligrams every 6 hours, and we're just in close communication. And I give them 2 or 3 days at a time, and we just check in. And I've never had a problem with a patient who has opioid addiction getting an opioid for pain, relapsing on their addiction as a result of this approach. So it can be safely done. You want to avoid co-prescribing opioids with other sedatives like benzodiazepines, because that's a setup for potential sedation and overdose. You want to offer, again, a short course of opioids. Typically 3 days or fewer is sufficient. And in fact, some states in the US actually put a cap on the number of opioids or number of days you're allowed to prescribe to a young person. And then you want to notify parents if it's a minor and review safe storage. Ask the parent to keep the medication locked up. Ask the parent to themselves dispense the medication to them. Even young adults who you're worried about, what I'll often do is, again, my patients with opioid addiction often have a friend or a partner that they can lean on, and they'll ask the friend or the partner to hold the medication for them and directly administer it to them just so that they can make sure that it's being given in the way that it's prescribed. I want to take a slight detour because this will go into the American Academy of Pediatrics recommendations, because this is a US FDA and also AAP recommended approach, and that is we should actually avoid codeine and tramadol. Why is that? I think sometimes we as pediatricians think, oh, oxycodone or hydrocodone, those are big opioids. Those are potent opioids. Let me do something lighter or softer, right? Something less potent. And so our minds go to codeine or tramadol. It actually turns out that codeine and tramadol are often metabolized differently by different people and can be a setup for overdose and oversedation. In particular, in young kids under the age of 12, and in adolescents aged 12 to 18 who might have some pre-existing breathing problems. So if somebody has severe lung disease, asthma, if somebody has obstructive sleep apnea or has large tonsils that may compromise the airway, layering on codeine or tramadol, which again can be metabolized differently by different people, can be a setup for breathing problems and sudden death. And so these medications are actually riskier than just giving hydrocodone or oxycodone, which don't have these same sort of odd metabolic metabolizing properties. So in general, I say it's probably best just not to prescribe these at all. If you're going to prescribe an opioid, use oxycodone or hydrocodone at a low dose. Okay. So that's the end of my sort of mid-talk detour into how to prescribe opioids appropriately, because I think that's important for us to know as pediatricians so that we can continue to treat pain effectively. But now I want to pivot back to talking about how do I identify teens who might be at risk of overdose or addiction, and then what do we do in terms of supporting them with treatment. And I put this slide up here just to show that we actually do a, unfortunately, very poor job in the United States of connecting young people to treatment. So this is a figure that we call the opioid use disorder cascade of care, meaning these are all the sort of steps that somebody who has a problem with addiction should get. The first thing that they should get is that they should be diagnosed. Then they should get some kind of treatment. Ideally, they get medication as part of their treatment, and we'll talk about that in a second. Ideally, they stay in treatment for at least 1 month, and then really, truly ideally, because this is a condition with chronic sort of disease elements to it, they should be retained in care for at least 6 months because of the risk of relapse. And in this figure, blue represents the number of teens that make it to that stage, and red represents the number of teens that don't make it to that next stage of this cascade. And so if you take all youth across the United States, which is again, about 1% of all teens nationwide has a problem with opioid use disorder. If you take that 1% of teens across the country, fewer than half are even diagnosed as having a problem. We don't even recognize that they have a problem, which means we need to screen. So we'll talk about that. And then see that at every stage along the way, they drop off. And so overall, we're not doing a good job of identifying young people who have problems and then getting them into and retained in treatment. And unfortunately, and I know that Dr. White would be really concerned about this, we do even worse when it comes to young people of color. At every step of the way, there are health disparities where Black and Hispanic youth are even less likely than white youth to make it to the next stage. And so we have a lot of work to do here. And so with that as the backdrop, here's some key questions that I think are important for us to know and that I want to make sure that we talk through. First of all, what is evidence-based treatment for opioid use disorder? What are we doing in our clinic to help teens? How should we screen for opioid use disorder? What are the ways that we can detect youth like Zach, who might have just low-level experimentation that we need to know about? And then when we do have teens that have problems, where can we refer them? And last of all, what are some additional simple things that every single one of us in this room can do starting today that's the easy stuff, even if we can't do the more complex stuff like actually treating youth? So the first thing I want to do is just talk through what is evidence-based treatment for opioid use disorder. And there are 3 FDA-approved medications for opioid use disorder. They are buprenorphine, which is FDA approved for teenagers, 16 and up. It's actually the only medication that's approved in the teenage group. Methadone, which is FDA approved for 18 and up, and naltrexone, which is FDA approved for 18 and up. And I'll talk a little bit about what are the various properties of these medications and how and why do we use them. But I'll just say that these are evidence-based medications that treat opioid withdrawal and treat cravings for opioids, which makes them really effective at helping keeping teens from using opioids. They result in better retention and addiction care, and they're recommended by the American Academy of Pediatrics and other major pediatric bodies. Medications are typically offered alongside behavioral health services, so teens typically get counseling when they get these medications, but some teens that I care for reject the counseling or don't engage in the counseling. These medications are so powerfully associated with survival and are clearly life-saving across clinical studies, so much so that if a teen rejects the counseling and does not want to engage with the counseling, even though I recommend it strongly to them, I still prescribe the medication to them because the data show us that the medications are still life-saving even if somebody doesn't engage in the counseling. It used to be that we all needed waivers to prescribe buprenorphine, had to do this really extensive training. We're no longer, that policy has changed at the federal level, and so any one of us can prescribe buprenorphine now, whereas we didn't used to be able to. And if any of you are interested, there's some great training opportunities at this website, pcssnow.org. And this cuts across specialties, and so if you're a pediatrician, there's stuff for pediatricians. If you're a dentist, if you're a clinical psychologist, if you're a social worker, if you're a nurse, there's something for everybody here. So let's talk just a little bit about these medications because they all, interestingly, each of the medications has a different mechanism of action, which I find fascinating. Buprenorphine is a partial opioid agonist, meaning that when it binds to the mu opioid receptors in the brain and throughout the body, it binds to it very tightly, in fact, but it doesn't have a full effect. And so that's actually a benefit of buprenorphine. It's actually really hard to overdose on buprenorphine because it has what we call a ceiling effect. As you take more and more buprenorphine, it sort of maxes out at the amount of effect it can have because it's only a partial agonist at the receptor. And so your breathing doesn't slow down. So it's a great treatment because it will help treat addiction, but without putting you at risk of overdose. As I said, it's FDA approved for teenagers 16 and up. We do sometimes use it off-label for younger ages when it's indicated. We just don't have a ton of data on it. It's available most commonly as a daily film or tablet that you place under the tongue sublingually, and then after 5 to 10 minutes, it dissolves and gets absorbed under the tongue. There's also a monthly injection called Sublocade. We've sort of done with these medications what we've done with, for example, birth control and hormonal contraception, right? If you want to prevent pregnancy, you can take a daily pill, or you can get an injection, or you can get an implant. There is a semi-annual implant for buprenorphine. The manufacturer, it hasn't proven to be very popular. It's a big implant. It's sort of cumbersome, not easy to put in. And so the manufacturer has actually stopped using it because the monthly injection is just so much handier to use. And as I said, buprenorphine can actually be prescribed by any primary care clinician, and this is a new policy here in the US. Methadone is a full opioid agonist, meaning that when it binds to the mu opioid receptor, it has a full effect at that receptor, and you can overdose on methadone because you can take too much of it. It has very limited access for people under the age of 18 in this country. It's unfortunate because methadone is a medication that's been sort of highly stigmatized. It's been, because of federal law, you can only get methadone if you go to a qualified methadone treatment program. Often those can feel like stigmatizing environments, especially for young people, because you have to line up every day, you have to go every day, you get administered an oral dose. It's a very sort of paternalistic form of treatment. Teens, practically speaking, can't get into these programs. Most programs won't take somebody under the age of 18. And then 19 and 20 and 21-year-olds who might go often feel like, this isn't the right place for me because I'm showing up alongside 50-year-olds who have been injecting heroin for 20 years. This doesn't feel like the right match for me. It's not developmentally a match. And it's unfortunate because actually across studies, methadone is the one that probably has the best treatment effect and the best survival effect. But it's just so limited. And we may see this policy change in the US. It might become, there's a big movement afoot right now, including some bills at the federal level that might make methadone more accessible for people. And then the last medication, naltrexone, is an opioid antagonist, meaning that it blocks the opioid receptor, which is an interesting mechanism of action. And we'll talk about why that works in a second. It's FDA approved for 18 and older. We do sometimes use it in younger kids. It's a daily tablet that people take. It's also available as a monthly injection that goes by the brand name Vivitrol. It can be provided by any primary care clinician as long as you sort of have access to it and store, the shot or the injection in your clinic, or you can prescribe the tablets to anybody, although there is a national back order right now. So these are the medications in our toolkit. And I think a lot of people will sort of ask the question, Why is it that you would use an opioid agonist to treat opioid addiction, right? And some families will quite frankly tell me, aren't you just treating one addiction with another? Here's why that's not correct. So when somebody's using heroin or fentanyl or short-acting pills, what happens is you use them, you get a blood level of them, and you start to feel euphoric, or you start to feel high. But because they're short-acting, you immediately start to metabolize them, and then in order to feel that again, you have to use again. And then you metabolize, and you have to use again, and you have to use again. And so you enter into this pattern of kind of using over and over and over again to get that high. But as you build up tolerance, that high gets harder to get. And as you use more and more, when you're not using, you start to get those withdrawal and cravings that we talked about. And so when you enter into this cycle of addiction, you actually are fighting really hard to just feel normal again. You actually spend very little time feeling normal. Or maybe you're even just using to even try to feel normal in the first place because these withdrawal and cravings are so miserable. And so that puts you into a cycle. What we do with buprenorphine and methadone, which are opioid agonists, is we wait until somebody has come down off of the last time that they used an opioid. And these are medications that, because they're prescribed and because they actually last for 24 hours, they're long-acting opioids, we can very carefully put them to a dose where somebody actually can live in this normal range, meaning that they're not experiencing uncomfortable withdrawal or cravings that are going to drive them to use, and they're not going to experience euphoria or high. And so they can actually go about their day-to-day activities. They can engage in behavioral counseling. They can go to school. They can go to their job. And they help people feel normal again. So that's the rationale behind an opioid agonist. And again, when a family says to me, aren't you just treating one addiction with another, I highlight what we talked about before, right? When you take something that makes you more functional rather than less functional, you're actually treating addiction. You're making the problems of addiction get better. And that's how we know that this is not treating one addiction with another. Now, the rationale for naltrexone is a little bit different. As I said, naltrexone is an opioid blocker. And mu opioid receptors that lead to that high, to those reinforcing effects, are kind of scattered throughout the brain, and they're especially concentrated in parts of the brain that feed into that dopaminergic reward center. And what we do with naltrexone is that basically we block the high from opioids, making it so that somebody doesn't get high when they use opioids, which blocks that reinforcing effect. Interestingly, naltrexone is this fascinating medication that has this additional effect. It turns out in the brain, when you crave something, if you're craving a breakfast sandwich, or if you're craving pizza, or if you're a teenager who engages in self-cutting behaviors and you are craving the feeling of cutting yourself, or if you are somebody who struggles with alcohol use disorder and you're craving alcohol, cravings are mediated by endogenous endorphins in the brain, endogenous opioid transmission within the brain. And so when you use naltrexone, you actually block those pathways, and you can reduce cravings for all kinds of different things. And so naltrexone is actually used not just as a treatment for opioid use disorder, but is used to treat people who struggle with alcohol, people who struggle with self-cutting behaviors, people who struggle with binge eating behaviors. It can be very helpful with cravings, just kind of writ large. So it's a really interesting medication that way. So with that as the backdrop, and thinking about how we want to make sure that people are getting evidence-based treatment, we will talk now about how to screen for substance use, how to refer for treatment. We'll talk about how we can talk to our patients and families about overdose prevention and harm reduction. And then we'll talk about how to change the way that we talk about addiction in a way that will reduce stigma in our healthcare settings. And we'll go through each of these in turn, because these are all things that we can do. So the first thing we can do, and granted, I get it, this is a little bit of a heavier lift in pediatric practice, but we can screen for substance use disorder. This is a screener that we use in our clinic. Every teen answers these questions alone in the exam room before I come in to see them on an iPad, and then it feeds into our electronic health record. And it asks teens, in the past year, how many times have you used tobacco, alcohol, or cannabis? Now, we actually have added in a question about vaping, recognizing that many teens vape and don't think of tobacco the way that we used to when this questionnaire was designed. And now we are also adding questions about counterfeit pills or about pills for teenagers, because it's possible to experiment with them. And the bottom line is you just say how often you've done this in the last year if you're a teenager. And note that the question presumes that you've used. It doesn't say, have you ever used these? It says, how many times did you use these? And that results in better sensitivity. It does a better job of detecting use, because it's much harder to say 0 if you're not using. And it's much easier to say 3 or 4 if you are using. So it results in a better screen. And just the frequency with which a young person uses is important because it maps to their risk of having a substance use disorder. Now, many of you might have a glass of wine with dinner, once a week, twice a week, 3 times a week. For adults, that's okay. For teenagers, that's actually unusual. And the data show that if a teen has used a substance not at all or just once or twice in the last year, they likely don't have a true substance use disorder. And this applies to whether it's opioids or nicotine, cannabis, whatever. But once they start to being at a point where they're using on average monthly, that correlates with them having a mild or moderate substance use disorder. And once they start using weekly or more frequently, that correlates with a severe substance use disorder. And that's important because I think we all have cared for patients who say, oh, I smoke cannabis every day, but I don't have a problem. I could stop at any time. Well, it turns out the data strongly suggests that if you were to dive deeper and ask them more questions about the problems they're having from that cannabis use, then you would find that they are having a lot of problems and they have a true substance use disorder. And for people who like test parameters like negative predictive values and sensitivities and specificities, suffice it to say the numbers are really good. This is a good screener. This is freely available online. You can just Google S2BI at this URL that's listed here through the federal government, and you can see the questions. And even if you don't have it incorporated into your medical record, there's a website that you can direct teens to that they can answer questions on. And then, of course, you need to know where to refer somebody who is having a problem. Here, I often direct people to what's called the SAMHSA Treatment Locator. This is run by the federal government, by the Substance Abuse and Mental Health Services Administration. The website is findtreatment.gov, and you can go in, type in the address of your patient, the address of the hospital, and you can go up to this place here and select different filters. And you can get a Google map of all the programs in your area that say, take teens and offer buprenorphine and accept Medicaid and our residential treatment programs. And you can sort of check off all these different boxes, and it will bring up all the treatment programs around you. I will caveat this by saying not every treatment program is high quality. In fact, we know a lot of them are low quality, but it's a good starting point to figure out what your resources are in your area. Okay, so that's the first thing we can do. We can screen and treat. The second thing we should do is we should talk about overdose prevention and harm reduction. And a colleague and I have a piece coming out in Pediatrics sometime in the next couple of months where we're really kind of making a call to action. And just in the same way that we as pediatricians talk to kids about wearing helmets, to family members about using car seats, to teens about wearing seatbelts when they're in the car. I think now that this is the third leading cause of death in teenagers, just as we talk about guns, just as we talk about motor vehicle safety, I think we now need to be talking about drug safety. And so for teens who are using, and teens that you think might be at risk of using, there's some things we want to do. Of course, we want to recommend to teens that they shouldn't use. That is critical. We absolutely should do that. And yet, for teens who are using and are not ready to cut back, there actually are ways that they can help keep themselves safe. And this is, I think, a difficult tension for us as pediatricians because what we want is for them to not use. But we have to acknowledge that even despite our recommendation and support, sometimes they will use. And so how do they keep themselves safe? Well, they should be aware of counterfeit pills and know that those pills commonly have fentanyl in them. Also, by the way, the heroin and cocaine supply in this country has a lot of fentanyl in it. So even those drugs are not safe. Teens should not use alone. They should use with somebody else if they're going to use so that somebody can call 911, and they should stagger their use. They should start with a little bit. Don't start with the whole tablet. Start with a half tablet or a quarter tablet so that you can assess its effect. Avoid mixing it with other substances that are sedating, including alcohol. If somebody overdoses, call 911. Here in California, in Massachusetts where I am, you have what's called a Good Samaritan law, which means that if somebody is overdosing and you call 911 and there are drugs on the scene, you can't be arrested for possession of drugs because the law protects you. The law says it's so critical that somebody gets medical attention that you should call 911 and we won't worry about the drugs. And then, of course, we should carry naloxone, and this is what naloxone looks like. It just became available over the counter in September, so you can purchase it at any drugstore. It's increasingly on Amazon and other places too. Unfortunately, it's not cheap. It's $45 for a kit of 2. So often still the cheapest way for your patients to get it is for you to prescribe it and then to run it through insurance because then it's often given with little or no copay. And I have some in my backpack. I carry it with me. I keep it in the junk drawer at home, that drawer in the kitchen that has like paper clips and pens and stuff in it. And I keep it central, just like we do our fire extinguisher. I'm not planning on burning down the house anytime soon, but I keep a fire extinguisher there just in case something happens, right? Of course I don't think that my 6 or 3-year-old is going to overdose on fentanyl, but what if they or somebody in the neighborhood had an issue and I could run to that junk drawer and help them, right? And then, of course, there are additional harm reduction approaches that we can offer to patients. Even when youth aren't ready or able to stop their substance use, we can help them by preventing HIV and testing for HIV. If they are at risk of hepatitis C, we can test and treat. And for teens who are injecting, and I will say this is relatively uncommon, injection drug use, most teens are either smoking or snorting fentanyl or swallowing the pills. But we could offer them syringe exchange, and California actually has a rich sort of history of syringe exchanges so that teens can at least get safe injecting equipment. And these services help to keep youth safe and build trust with you as a clinician. Data show that when you do these things, people don't go on to use more drugs. They just use the drugs that they were probably going to use anyway, and then they have a trusted clinician that they can turn to when they do want treatment. There are fentanyl test strips. This is what a fentanyl test strip looks like. If you wanted to test a tablet that you were about to take as a teenager, you would add a small amount of drug to a clean, dry container, add a little bit of water to it, mix it up, dip one of these fentanyl test strips in it, lay it flat on the surface of a table for 2 minutes, and then see if, so they're kind of the opposite of COVID tests and the opposite of pregnancy tests. They start off with 2 lines and they go down to 1 if it's positive, and they stay 2 lines if it's negative. I find that confusing. But teens could test their drugs. I will say I have limited enthusiasm for these. I think they're great. I talk to teens about them. I use them as a centerpiece for, I care so much about your safety that I'm going to talk to you about this thing. But we live in a world in which everything should be presumed to have fentanyl in it. So that's actually the central teaching, is that you should just assume what you're about to take has fentanyl in it. And you can test, but it's probably got fentanyl in it. And if the test is negative, it probably still has fentanyl in it, and maybe you tested the wrong part of the tablet that just didn't have a lot in it, or maybe you tested it wrong, and you should still just presume it's got fentanyl in it. But I think these are a nice safety piece, a nice prop for me to have a thoughtful conversation. And here in the last moment here, I just want to talk about this third thing, and that's how do we change and reshape the way that we talk about addiction. We generate a lot of stigma in our healthcare environments, right? I'm sure you all have heard this at various points in time. I probably have inadvertently, or in some cases maybe even, on a bad day, contributed to this. And that is that we use really sort of ugly terminology to talk about people who struggle with addiction. And you see this in the press all the time too, by the way, right? And just in the same way that we don't say, in bed, 312 is a 16-year-old asthmatic, right? We're trying to move towards using the person first and the illness second, right? Instead of saying, oh, that's an addict, we should say, oh, it's a person with a substance use disorder. And by doing so, we humanize people. We put the person first. And I will actually just say, you might think I'm sort of being language police here. That's not my intention. I just want to create nice, affirming, welcoming places for people who struggle. But actually, there are clinical trial data to show that when you use more stigmatizing language, patients get less good treatment. So the language actually results in worse care if we use the wrong words. I will highlight that actually even the term substance abuse, for us as pediatricians, when I hear the word abuse, I think of sexual abuse, physical abuse, emotional abuse. I think of really sort of dark, difficult things that hurt me a lot as a provider when I have to sort of venture into those spaces. Substance abuse is actually it's not really abuse, it's just sort of use or misuse. And so I encourage people to actually move away from using the term substance abuse because, interestingly, this is a term that is just problematic enough that it does result in clinicians using different approaches with their patients. And there's a few other problematic terms here. I want to highlight this last one. Babies who are born exposed to opioids and have neonatal opioid withdrawal syndrome. We should not talk about them as being born addicted. We talked about addiction being a very complex set of behaviors. Newborns don't have those behaviors, and so it's really stigmatizing for families to hear, oh, your baby was born addicted to opioids. It's much better to say your baby was born exposed to opioids, and I think that's better for families to hear. So with that as the backdrop, here's some simple things that I think we can all do, and thank you so much.
I'm sure there are tons of questions. We've got about 10 minutes for questions, so if you raise your hand, I'll come to you with the microphone, If you'll speak very loudly, slowly, and clearly, that will help us.
Thank you for an excellent lecture. My question is about, since we use Suboxone in split doses to treat acute pain in patients who have chronic pain, do you ever foresee, as an addiction medicine specialist, where we're going to quit giving opioids altogether and just use Suboxone or something like that to treat acute pain?
Oh, I think that's a great question. And in fact, I talked about the scenario in which I have patients who might have opioid addiction and then have severe acute pain because of a surgery, and then I treat them with oxycodone on top of it. Another alternative approach is to do exactly what you said, treat with Suboxone or buprenorphine, and treat with higher doses. I think it's possible. I actually am seeing it a little bit more and more, especially in patients with chronic pain, rather than giving them MS-Contin or OxyContin, these sort of full opioid agonists kind of around the clock. Increasingly, we're in patients that we think might be a setup for struggling with addiction, we'll use buprenorphine. So I think in certain scenarios, we're absolutely moving that way. I think we'll need some clinical trial data to see if that's the best approach for everybody, but there is absolutely promise there. Yeah, that's a great question.
Hi, Maria Chandler, I'm a pediatrician. I'm wondering if you know about and you have an opinion about a new law in California protecting the rights of residents for cannabis use, and that they cannot be discriminated against by employers. And in fact, many employers have dropped drug screening on pre-employment physicals. And it's really confused a lot of us, especially if you receive federal funding and you're required to do that. Mm-hmm. So I don't know if you have an opinion on that.
Yeah, it's really tricky. You know, the studies show that for young people, they commonly use cannabis before they move to using opioids. So that led a lot of people to think, is cannabis kind of a gateway drug, right? Does cannabis use lead to people using opioids? It's probably more so the case that, just like we saw in that earlier slide, some teens are probably at risk of substance use, period, and just happen to come across cannabis before they then later on have, you know, because cannabis is easy to get to. So if you're going to use substances, that's going to be the one that you have ready access to. It's a little bit harder to get the other substances. So, I worry a little bit about us being a little bit too sort of open about liberalizing cannabis and making it widely available, because I think it does send mixed messages to young people.
And what about the functionality of somebody on cannabis at work, especially in healthcare, maybe a provider,
right,
you know, in that situation?
Right, so on the adult side, I worry about that a little bit too. The studies show that these laws haven't yet contributed to more cannabis use, interestingly, but what it probably has done in young people is contributed to, among young people who were using cannabis, to using more intensely. You know, using more frequently, using daily or near daily. And so I do worry about these messages sort of resulting in different use patterns. So I share the same worry. And I also worry about somebody being intoxicated on the job, absolutely. Or a teen being in school and being, you know, under the influence of cannabis and unable to learn as a result. I worry about that. And I think it is clear in my practice, because I treat teens all the time with cannabis use disorder, that it can result in problems that are clinically significant and get in the way of life. So absolutely. I don't know about drug screening. The studies show that probably drug screening, routine drug screening of everybody for employment or education, probably results in more harm than good, even though we do it all the time, because it takes people who have maybe infrequent cannabis use that probably isn't clinically significant, might just happen on a Saturday night, and punishes them sort of unnecessarily. The people who are intensely using probably get detected in other ways.
And we've been told, we're trying to learn, that, like, for example, the saliva test tests for more short-term use. It doesn't stay positive for 3 months like your hair. And right. We were using urine, which they said can stay positive. So I don't know if there might be better ways to find, because if you test them and they're positive that moment, mm-hmm. when they might know they're going to get a test, that maybe that's an indicator of daily use. I don't know, and I don't expect answers right now.
No, I think that's very true, that that there are different what we call matrices of testing, different things that you can draw samples from and get different answers from. So hair, it stays in hair for a very long time, 6 months to a year at times. Saliva, much quicker. Urine is somewhere in between. People's urine will stay positive for at least a week to a month after last cannabis use, so that becomes difficult to know what to do with a positive test. But I think with all things drugs, probably the most important thing we can do as clinicians is look to the data and be sensible. And I think that's what I hear you doing, is sort of like grappling with the fact that there's not one clear answer here, but there are pros and cons to these policies and unintended consequences. And it's up to us to speak out about what we see. Yeah.
Question right here.
Hi, my name is Ioana Powell. I'm actually a clinical psychologist. I work with teens and kids. I did work in a methadone clinic in Lynn, Massachusetts, actually, for a year. My question is this. I know you mentioned that not all teens will go into treatment and therapy. For those who do, what have you found out to be more useful in your practice? Group DBT, individual therapy, family therapy, what have you found to be the most useful when they do both medication and therapy?
Great. Thank you for your hard work up in Lynn. I have a lot of patients up in Lynn, so that means a lot that you were doing good work for the community there. I think it's tailored. I think different teens need different things. I have some teens who thrive in group therapy and really love it. Other teens who don't want to be around other teens talking about this and do better with individual therapy. Some teens who do great with DBT, which is dialectical behavioral therapy. Other teens that do better with cognitive behavioral therapy, which is related but slightly different. I think different things. I think, in my mind, the teens that do best are the teens that ultimately, maybe not initially, but in the, sort of like 2, 3, 4, 5, 6 months into treatment and beyond, have positive life experiences or positive life goals that they can work towards. A family that loves them that they can re-engage with, friends that are meaningful to them that don't use drugs, getting back into school and pursuing their dreams. That actually is much, much, much more important, I think, than the buprenorphine that we give them in the clinic that initially stabilizes them. I really think it's that long-term recovery element that's so needed. I bet you feel the same way too, based on your work, right?
Hi, great lecture, and I learned a lot of new things, even though I heard you a couple months ago. I think one thing that I've read about pain in general is that our expectations of pain determines how we interpret it. I was on leadership positions in the hospital when JACO, you had to have no pain post-op, and having people not expect any pain having a baby or post-surgery makes it that you need more and more pain medication. But if you expect that pain and you accept that pain, there's some cognitive behavioral therapy they use in England because they don't have all the doctors and psychiatrists and everything. Could you comment on that? I think it's fascinating.
Yeah, I think that's absolutely right. Having even just the expectation or understanding of what pain is to come after a surgery, I think really helps people to understand or to contextualize the pain that they then experience, to understand that pain is expected, pain is normal after what you've gone through, and now we're managing it, rather than pain is catastrophic, how am I going to go on? This is enormously distressful. Those are two very different clinical
And
scenarios.
to mask it so completely that if you have a complication and you don't notice it, can be fatal.
Right, exactly.
And that's
right, and I think managing those expectations also helps people to discontinue an opioid when they might be ready to, right? Understanding that, well, I've gotten my pain down to where it's mostly gone on an opioid. I'm going to try coming off of it now, and maybe I'll tolerate a little bit of pain as I do that, knowing that overall, I'm going to experience some pain, but it's going to get better. I think that orientation is really helpful. Yeah.
If I can throw in a comment related to that as well, a lot of times when people are out of control with their pain, it's because they feel out of control with their pain. And so when you can talk ahead of time, like you were saying, the expectation of pain and empowering them, you can control this to some extent. So it's not just controlling the expectation, it's empowering the people to be able to control the pain. Very psychological, very, very helpful. So, all right, well, thank you again so very, very much. One of the things I said to start was that after getting to know Dr. Hadland a bit, I knew that he was the right one, as did our team that was reviewing potential speakers. How many of you would agree that he was the right one today? Yeah, very, very good. And we're very appreciative of your work. We're very appreciative of your taking time away from your family to be here with us. Thank you for all that you do for others. So very, very well done. So now we have a small follow-up. We know that furthering Dr. White's legacy of contributing to the community is important. And so we want to focus on how we are doing that actually in Long Beach with the Long Beach Department of Health as well as the Long Beach Unified School District. Our first speaker, who will speak very briefly to this topic, is Dr. Andrew Abayan, and he will provide us with a summary of the Long Beach Health Department's response to the opioid epidemic. Dr. Abayan is the Community Engagement Liaison at the Long Beach Department of Health and Human Services in the HIV Syndemic Policy Program. Dr. Abayan coordinates the opioid prevention and control activities for the Long Beach Health Department. He has a master's degree in biomedical sciences and an MD degree. He transitioned from a family medicine residency to a career in public health. Very admirable. He also has been working with a diverse community service background and specifically with those who experience homelessness and has developed many programs to serve others. Following him will be Dr. Aaron Simon from the Long Beach Unified School District. Dr. Simon will share with us the fentanyl prevention and response efforts in the district. She leads many reform efforts in school districts in her current role as Assistant Superintendent of School Support Services for LBUSD. She leads the direction of the Special Education and Student Support Divisions, High School Wellness Centers, and the Family Resource Centers, which provide social, emotional, and behavioral health-related support to students within a cluster of schools in the Long Beach Unified School District, and provides much guidance to all of the area schools and health agencies. So please welcome first Dr. Abayan.
Hello, everyone. My name is Andrew. I work at the Health Department and specifically the HIV Syndemic Policy Program. I'm just going to talk about what we're doing in Long Beach as part of the Health Department on combating this opioid crisis that's been going on for a very long time. So here are kind of my objectives. First, I'm going to start with saying I have a really bad habit of putting a lot in a presentation for the time frame, so I'm going to try and get through all this. So first, we're going to talk about some data in Long Beach about opioid overdoses. We're going to talk about our HIV-STI syndemic strategy. And then we're going to talk about the harm reduction distribution program, and then a little bit more of the strategies we are taking to decrease all the effects of opioid use and overdoses. There we go. So first, data. So as Dr. Hadland had already talked about, opioid epidemic has really affected so many people over many decades. It can be kind of categorized in three waves. First with prescription opioids in like the late 90s, early 2000s, and then increasing with like heroin in 2010. And then now really, I think most significant has been fentanyl and other synthetic opioids that have really taken over the illicit drug supply. So what specifically is happening in Long Beach? There we go. So over the time frame of 2018 to 2022, there have been 294 deaths due to opioid overdose. Within that same time frame, when you break it down by opioid type, fentanyl has caused 234 of those, meaning 80% has basically caused the deaths. So it really shows how much fentanyl has taken over the drug supply and also just overdose deaths. We took that data and we kind of used the demographics from death certificates and showed kind of what populations are being most affected. So to say it in kind of one sentence, males between the ages of 19 to 39 who are Latinx, white, and live in the zip codes of 90813, 90802, and 90804 are really the most affected and most dying from opioid overdoses in Long Beach. As Dr. Hadland had talked about, there's a lot of polydrug overdoses happening. And so with the data that we received, 55% of those opioid-related deaths involved a stimulant, and of those deaths, 45% of them were methamphetamine. So while we are talking about fentanyl, there is still a problem with other drugs also that are involved in these deaths as well. We also took a look at overdose response calls from EMS and Long Beach Fire Department. From mid-2019 to 2023, there were 1,300 overdose response calls related to opioids. As you can see, kind of the numbers increased from 2019 to 2022. And then if you look at the, right over here, we don't really get any more demographics other than age group and gender or sex. But basically the same thing, males between the ages between 19 to 39 are exhibiting signs of an overdose due to opioids. There we go. And this is just kind of a map showing where all they are happening in Long Beach. All the red dots are an opioid overdose response call. As we can see, kind of with the map of where all the deaths are occurring, the opioid overdose response calls are also occurring in those same zip codes. So that's all for the data. I really want to briefly touch on the HIV/STI syndemic strategy that our program is kind of taking the lead on. You're probably wondering why I'm talking about an HIV/STI strategy when we're talking about opioids, and I'll get to that in a little bit. So in 2019, the city put together a strategy to decrease the rates of HIV and STIs in the city. They realized that there was a lot of cases within Long Beach, and we needed to do something about it. And so they put together a strategy with 5 goals in mind: reducing the overall number of infections, strengthen the capacity to address it, educate communities on HIV prevention, STI prevention, testing, and treatment, and then increasing access and engagement regarding all these things and expanding PrEP. We are planning on putting out a new one, but there are 2 new things that we wanted to do. One, we wanted to increase community engagement so the community can help us develop it. Also, we also wanted to put with a perspective of syndemic strategy. What is a syndemic? So it's really when there's 2 or more social or health conditions within a population. And so one example I can give is if someone is experiencing homelessness, living on the streets, they may have a mental health condition or they might be using drugs. If they are injecting drugs, that increases their chance of getting HIV, or they may be also having sex for money or whatnot, which puts them at increased chance of getting STI or an HIV. Now, if you're all clinicians and treat patients, treating the whole person isn't more important than just treating the disease that they may be living with. So you need to help them with the HIV, but you also need to make sure that they are also getting taken care of where they're living or all the other social determinants of health that we all talk about. Otherwise, you're just treating the disease and not so much helping the person get better health outcomes in the overall long run. So what we're trying to do with this strategy is to really get feedback from everyone, from every different population within the city of Long Beach, and asking what can we do well, or what are we doing well, what can we improve upon, and solutions so that we are making a concerted effort to think about everything in a syndemic perspective. And then these are just a list of kind of all the listening sessions and all the communities we're talking about. These are just a few. There are so many populations that make up Long Beach, which makes Long Beach so great. And so these are all kind of the ones that we're trying to focus on. As you can see, we're trying to get youth perspective as well, which I know is just a lot of interest for all of you as well. So now I'm going to get into the meat of all of this. What are we doing? So first is the harm reduction distribution program. Our program really exists due to the opioid settlement funds that have kind of been coming into play the last few years. If you don't know, a lot of the pharmaceutical companies and their distributors went through many lawsuits because of the effects that they had in the opioid crisis. So we got some of that money and we are putting it to use through giving out harm reduction materials. So our program provides Narcan and fentanyl and xylazine test strips for free to the community of Long Beach and some surrounding areas. They can currently obtain them through ordering from our website. We are trying to figure out how other ways they can get them if they don't have a computer or technology. We do get our Narcan from the state. So that really kind of hampers who we can give it to, but mainly we can give it directly to the community members, not so much organizations that can distribute it out for us. So we want to see where it's going and who's getting it. So how does the community order? So we do have a website, which I'll get into, but basically they can put in their order at request on the request forms. They'll come to me, and I will give it to them. They can come pick it up at our main health building. We want absolutely no barriers in any way, so they can get this for free, because I know how expensive Narcan can be, just for 2 little doses. And so we wanted it free and absolutely no barriers. I'm sure you all have seen Narcan. And then these are the types of fentanyl test strips that we do have. We also have xylazine test strips from the same company as well. So other forms of distribution. So we are working with a lot of the other health department offices, as our health department is very big. There are many components to it. So we do have a multi-service center that provides services to people experiencing homelessness, also run by our Homelessness Service Bureau. So they have a bunch of outreach teams. So we are giving them the Narcan and the fentanyl test strips to go and distribute out so that we can reach more people. We also plan on working with them to get a vending machine that distributes out the Narcan and the test strips in the multi-service center. So if people want it and don't want to have to interact with anyone, they can get it for free as well. We do have a mobile testing unit that provides HIV and STI testing that goes around the city in various places. We're working with them so they can also distribute it for us. And then within our main health department, we do have a sexual health clinic and an HIV clinic where they will also help us distribute this out. And then within the health department, there are other departments with public health nurses, outreach workers, and other staff that are going to help us distribute it out so we can really get it to as many people as possible to prevent more overdoses and deaths. So what have we done so far? So I would say we've been up and running for about 2.5 months, but really February 21st, when there was a press release, that's when we got the most orders. And so as of the 29th of February, we've had more than 430 orders from community members. There was about 1,200 Narcan ordered, and then about 4,000 each of the test strips. In terms of distribution, which has kind of been the rate limiting step for this, Narcan that's been distributed has about 100, and then about 1,200 to 1,400 each for test strips. So people are wanting it, and people are coming to get it. And the test strips are mainly going out to community-based organizations that can do that work for us as well. And so lastly, I wanted to touch on some other strategies that are more than just passing out harm reduction supplies. So education, prevention, and outreach. There we go. So our main form of education is our website. So it's at longbeach.gov/harm reduction under the HIV Syndemic Policy Program. There we go. Our website has this little icon like menu. So here will be when the strategy is done and all the data that I talked to you all about. When that report gets done, it'll be posted here for your viewing. We talk about opioids and what they are, what MAT is, and what are the symptoms of an opioid overdose. This is where people can order. This is where any trainings that we will have, which I'll talk about, like scheduling, will be provided, and all of the PowerPoints. And if people want education, like educational trainings on whether it's Narcan, opioid prevention, or HIV, STIs, everything that we kind of cover, they can request, and we'll help them get a training for them. Provider resources for anyone providing any of this kind of work or this treatment on best ways to prescribe or stuff like that. Some resources will be here. And then this is kind of a screenshot of the community resources. So I've put together a list and a map of where all the substance use resources are in Long Beach. It is still a work in progress as I find more as they come to me as I do my work. But so people can find them, they have an address, they have the hours, what services they provide. So it's just easier for people to find as opposed to going through Google and the depths of the World Wide Web. There are hotlines for people to call if they need them, and then there's also national and state resources regarding all of this as well that people can look up. Other things that are in the works regarding the website is we want to transition some of that material into print information for people who don't have access to a computer or don't want to use technology, specifically when we're doing outreach. There is a syringe kiosk map or like a needle disposal map where people can dispose of their needles or sharps or whatever they're using so that they can get rid of them appropriately and not leave them on the ground or reuse them. And then we also want to provide more information regarding other types of harm reduction, so safe smoking, safe techniques for injections, et cetera, et cetera. Come on. Okay. I talked about the opioid settlement funds briefly, but we want to provide some of that money to other people doing this work. So one of the things that we're doing is we're going to try and get a educational youth campaign. So we want to work with an organization within Long Beach to do a campaign directed towards the youth ages between 12 to 24 about opioids, fentanyl, overdose prevention, and harm reduction. So our goal is to get a youth-directed group to provide a campaign targeted for the youth, as opposed to someone else that may not have worked with youth. We feel like it's having a greater impact if the youth is creating it and directing it towards their own peers. We've also put out an RFP to fund a community-based organization that provides harm reduction services as well as syringe exchange services in Long Beach. And hopefully this will enhance their work and build their capacity to do this work within Long Beach, things that we can't do at the health department. And then, like I talked about before, we want to provide community lectures and trainings on how to use Narcan, what's overdose prevention and harm reduction, kind of like an opioids 101 for people who don't know, and hit those spots that may be affected by this more, but also just everyone. As we know, fentanyl has kind of affected everyone, and everyone should be able to understand what it is and be able to instruct people on how to use Narcan and use it themselves. And lastly, city events. Long Beach has a lot of city events, and so we want to be out there, getting the word out, being advocates, bringing awareness to this crisis, and also giving out all of our harm reduction supplies. And I think I have one more slide. There we go. We also know that there's concerts and musical festivals here in Long Beach, and so providing test strips out there for people to use them while they're using or at the festival, just so they're more knowledgeable about what the drugs that they're using are. And lastly, so we do have a syringe service provider work group, and so this is a group of all the organizations and stakeholders within Long Beach that provide harm reduction services or syringe exchange services. And we kind of coordinate efforts, all of our efforts to decrease overdoses and get all of these services out there. And we also kind of bring advocacy and awareness to the issue. And one example is we had our first ever International Overdose Awareness Day last August. At the Multi-Service Center. We all came together and had a moment of silence, but also kind of a moment of remembrance for all those people whose lives were lost to an overdose. And we want to continue doing that again and putting more events on to show everyone what this is and what's been going on and how we can solve it. And that's all it from me.
It's amazing that Long Beach has this kind of service availability. And my guess is that many of you didn't know how accessible some of these test strips are, the educational programs. Long Beach is well prepared, and with your continued support and interest, we can continue keeping that up to save our youth. And you'll hear from Dr. Simon how the health department and the Long Beach Unified School District have worked together in order to ensure that the Long Beach Unified School District has access to many of these resources. So that's why we wanted to make sure you heard from these two great folks. Dr. Simon?
Good morning, esteemed guests. How are you? All right. So first, a huge thanks to Dr. Jenna Martin for this opportunity, to Dr. White's family. It's a pleasure to be with you today, and to Dr. Hadland, just thank you so much for your presentation. You've just reminded us that there's so much work to do, especially around educating and informing our students, our parents, families, our communities about the opioid crisis. We know that it is extremely important. So I'm going to talk about the fentanyl prevention and response efforts at LBUSD. And first, we're going to go into Ed Code. I'm not going to go over Ed Code. I'm not going to bore you all today. But Ed Code, the section 49414.3, which authorizes school districts to provide emergency naloxone to school nurses or trained personnel who have volunteered, to use naloxone. And when it says volunteered, I want to say we strongly encourage, right, many of our members at the school site to be trained on this. And this includes our principals, this includes our counselors, our social workers, of course, our nurses, and many others as they are at the forefront of the school. It also states that a school district can designate one or more volunteers to receive that initial training, and just know that our administrator of student health services, we call her our lead nurse in so many ways, Ms. Rose Van Meeveren, if you could just wave your hand. She is responsible and supervises around 60 nurses, district nurses in our district, and so she initially ensures they are trained, and they're the one to train our school site personnel at the site for that initial training, and then for that annual refresher every single year. So that is our responsibility to do that. Our outside partnerships, we worked with our student health services under the direction of Rose Van Meeveren. We partnered with the Los Angeles County Office of Education, and then also the California Department of Public Health to learn about naloxone, and then also how to obtain it. So really working with them to understand. There were a lot of sessions that LACO held for school districts to really understand their responsibility, how to draft policy, so on and so forth. So there was some in-depth work that our school staff, our district staff, did to ensure that we were on point and build our partnerships in that way. We also created a policy bulletin to really explain how we're going to administer naloxone under the guidelines of, the general guidelines, but also the division of responsibilities and who's responsible for storing and for using, again, based on folks who have been trained, and then also the emergency administration of naloxone as well was part of that bulletin as well. Once we drafted that policy, Student Health Services, again under the direction of Mrs. Rose Van Meeveren, sent this document to Dr. Anissa Davis. I don't know if she's here today. I thought I saw her, thank you. I thought we spoke at the coffee table. Again, hello, Dr. Davis. And so we submitted that policy to her for her review, just to make sure that we were on point and followed the policy to the T with the guidelines and such, especially around training and the storage, again, to ensure that we were on point with our policy. So just breaking down the general guidelines, I'm not going to read, but just for you all to have in regards to what the guidelines say and how it allows districts to obtain naloxone through its naloxone distribution project. So it provides that instruction for administrators, the storing of Narcan, which we have a place that we store Narcan, and everyone knows that. That's on that school site. And then how do we maintain Narcan as well? Site administrators, their responsibility. What is their responsibility? And that's to ensure they are coordinating with that credentialed school nurse at the site, and that there are monthly checklists, right, that are being adhered to, as well as also maintaining confidential files at the site as well. And then also for the emergency administration of naloxone, Narcan, we know that if a person is having the following symptoms or having symptoms around that, how we administer the Narcan, but we also call 911 for assistance as well. And then brief, I was told to be brief, so I gave you a few slides, but I'll be happy to answer any questions about, again, what we do, our trainings, so on and so forth. And again, thank you for this opportunity. I appreciate each of you. Thank you.
So questions for our team here?
Thank you very much. Just for both of you, what kind of education is being done at schools to kind of prevent the situation that happened to Zach that Dr. Hadland discussed, which is taking a pill, experimenting, and then having a bad outcome in terms of recognition that anything can have fentanyl in it, essentially everything that has fentanyl in it, to take that could be a risk that could lead to a bad outcome that happened with Zach. And then also kind of to segue to the fentanyl strip phenomena as well, which is, should we be, they may have their use, but should we be pushing a message of the strips are not necessary, well, not necessary, but the strips may be excessive because everything has fentanyl in it. Should that be a message that we should try to push more?
I'll speak from a school district perspective. We do have our school counselors who are providing just information, right, around this fentanyl, just in general, and opioids. We also have the pleasure of having family resource centers that are at our elementary sites, and yes, we do try to provide information at a very age-appropriate right level, just for our students to understand overall just drugs in general and how they're dangerous and so on and so forth. At our middle schools and our high schools, we do have wellness centers to where we have a social worker who is at those sites every single day. And so they bring students in, they have different topics. One topic is about fentanyl and about the opioid crisis in regards to providing our students just education around that. I would say I believe that we need to amp up the education and information to our parents and our families, our guardians, our communities, and I think that's something that we can do. I'm looking to our partners here with our community partners, right, to elevate the sense of urgency around that. I think sometimes our parents don't realize the sense of urgency, or sometimes they just don't know. Maybe they're naive in regards to maybe some things that are happening out within our community that could impact our students. And so how do we educate and inform our parents and our guardians and our communities, and so they are aware of what's happening in our community as well?
Hi, my name is Susan Vaughn. I'm one of Dr. White's granddaughters. I have a question for Dr. Hadland, and then I also have a statement. So I guess my statement first would be, I wanted to address the fentanyl test strips, and a concern that I thought of is when you're giving a adolescent the test strips, and like you said, Dr. Hadland, you can only test, a certain part of the pill, correct? So my concern would be that you're saying, okay, it's okay to take the pill now because you can test part of it, but what if they test the part that doesn't have, the fentanyl in it? They're going to die from that anyway. So I'm just afraid that that narrative would say, okay, it's safe to take, now we can all take the pill, when it really isn't. And then my question is, what are you seeing as far as, because I'm personally seeing this quite a bit, where they are taking the methadone, but they're still getting high off the opioids or the fentanyl, so it's a double high they're getting. So what are your thoughts on and what you've been seeing with that?
Yeah, just to your first comment on sort of testing the wrong part of a pill, we call that the chocolate chip cookie effect, right? The idea is if you make a batch of chocolate chip cookies and imagine the chocolate chips to be the fentanyl and then the cookie dough part of it to be the rest of the inert sort of additives to the pill. You could imagine a scenario in which you, like if you're doing a test of chocolate chips, you might break off the wrong part of a cookie and actually have no chocolate chips in it. And yet the rest of the cookie could have chocolate chips in it. So we do worry about that a lot. So I talk to teens about that when I'm giving the fentanyl test strip. And that's why at the end of it, I often say, even if you're reassured by what it is that you're about to take, you gotta, if you're gonna use, again, I recommend you don't, if you're gonna use, understand there still could be fentanyl in there. You wanna start with a little bit, just to understand what it is you're getting yourself into. The second question, what if somebody is on methadone, or actually this can happen with buprenorphine too, and they continue to use opioids on top of it? Let's say they're on those medications and then they go and use fentanyl. It actually turns out that these medications have what we call a blockade effect. And because they bind so tightly to opioid receptors in the body, they actually block other opioids from being able to bind so tightly. So they actually have a protective effect, meaning that it's actually harder to overdose on fentanyl when you have methadone or buprenorphine in your system, because those medications are blocking your opioid receptors. So it actually becomes more difficult to overdose. So it actually is protective. And that's part of the life-saving benefits of these medications.
Hi, I'm Lee. I'm a nurse practitioner here and prescriber of opioids. Just curious, and this might be towards Dr. Hadland or maybe someone from the health department, are there any drawbacks to using Narcan? Basically, if you're called to a scene, whether it's in your neighborhood or wherever, that you're at the store, is there any drawback to just saying this could be an overdose, I'm going to give the Narcan?
I believe no. So it's really only for people who are going or having symptoms of an opioid overdose. So it's only going to work if they have taken opioids, or even if they didn't know that they were taking opioids. So, I mean, if there's something else going on, it may not do anything, so that might help you figure out, oh, this isn't an opioid overdose. Maybe they have a low blood sugar, because hypoglycemia can mimic an opioid overdose. So I believe no would be, I guess, the best answer in terms of if it has any drawbacks. Yeah.
Yeah, I think that's absolutely right. I mean, it is always the right answer if you think somebody's overdosed to give Narcan and call 911. And I think the point about something else could be going on is the reason you want to call 911, right? Like, what if somebody's had a stroke and you get it wrong? You want to make sure they get that definitive medical attention. To get in the weeds a little bit, if you have somebody who has been using opioids and maybe struggling with addiction, and they go into withdrawal when they're not using opioids, if you spray Narcan up their nose, they could go into opioid withdrawal, which is very uncomfortable. So that's like one potential sort of side effect, but it's not fatal, it's just uncomfortable. And the risk-benefit ratio is such that if you're ever worried about someone, it is always better to save their life, even if the potential drawback is that they're uncomfortable for a period of time.
I have a question about the test strips and actual use. Dr. Hadland, or either of you who work with the schools or Long Beach Public Health, have actual patients told you about their clinical experience using the test strips? Like, are they effective? Do they take the time to use them if they're hot to use the drugs? And I'm just wondering how they really work in practical reality.
So since I've been at the health department, I haven't had anyone tell me specifically from the ones that we've given out, but from organizations that I've worked with who do give out the test strips, they see they're very useful. And people do use them, whether it's, even if they know that there might be fentanyl in it already, or it just gives them how do I say it, a better idea of what they're using. Just to make sure that there's fentanyl or not, or maybe they just assume that there's fentanyl already. A lot of harm reduction specialists do swear on them and love to use them and to provide them for their clients. From my experience working out on the streets of Skid Row, I did provide test strips to people, and they were really in demand. And so, yeah, I don't know if that answered your question. Yeah, okay, cool.
Before we move on to the next question, I just want to note that today is International Women's Day, and in recognition, thank you, and in recognition of that, the person who just asked this last question is Dr. Vernon, the first woman chief of staff at St. Mary's Hospital.
Congratulations. I have a question regarding Long Beach and schools in general in our area. Looking through the filter of accessibility and inclusion, how are we and what are we doing in terms of the more vulnerable population, the special education kids, in terms of distributing the information to the parents who may be overwhelmed with other issues, in terms of including them in this education?
Thank you for your question. So we do have in our district special committees, right, that for affinity groups or just really affirm, for example, our families, our students with disabilities. So we do have a group that we meet with every month. And so we do bring in district staff, right, to have conversations around hot topics, right, that are happening within a community, that are happening within the educational setting, our mental health, behavior, so on and so forth. Although we've had initial conversations, again, we have so much more work to do just around that. So trying to find just creative ways to where parents are already engaged or maybe having conversations. I'm not sure if it's appropriate, maybe to have it at the IEP meeting, but other spaces to where we can bring our parents in to continue, right, to have conversations around topics such as this. Thank you.
Great. Well, I want to thank you all very, very much for your participation and your contributions. Let's give them a round of applause, please. And so in closing, I want to thank you all for your attendance, your questions, your curiosity, your caring. means a great deal. I want to thank some really special people without whom this event would not have gone as it did. I certainly want to thank, and she's at another conference today, but Azi Jalali, who is the Executive Director of the Center of Health Education and Medical Education, Angel Arvizu, who is the lead of the Center of Health Education and Medical Education, and Patty Pina, who is also in that department. We certainly want to thank Dr. David Mashalik for his help. David, you've been wonderful in helping us get our meetings together, and you were one of the ones who pointed out to us Dr. Hadland, and so we're appreciative of that. And we thank you for all you do to support the Katherine White Lectureship series. We really do. Also want to thank Crystal McEachern, who is the Marketing Communications Specialist, who helped us with the brochure and with lining things up. And we also, I haven't seen him this morning, but we also want to thank Yair Katz, who is Chief Executive of Miller Children's and Women's Hospital in Long Beach and Senior Vice President of Pediatrics and MemorialCare, for his support and the Foundation's support for us to continue this excellent event in person. We had a fabulous attendance today, and it is recorded, as it was mentioned to begin with, so that this valuable information can be shared with many more people. You can re-watch it if you wish. If there's something you really want to take from the recording, it's available to you in a while. We have to get it all edited and all of that. But again, I want to thank you. I want to thank the family of Dr. Katherine White for continuing to be very prominent in their communities, helping others and helping us remember Dr. White. And certainly we want to thank Dr. White with all of our hearts. So have a good rest of the day. We'll see you next year. Thank you.